Thanks a lot for having me here. It's a kind of a unique thing for me to speak to a bunch of football coaches. I've never done this before. I got to say, though, my kid only listens to you guys. He doesn't listen to me. That's him right there. So he's not exactly, as someone was saying earlier, not every kid looks the same who plays football. Obviously, my kid doesn't look like a football player. But he had 8 out of 13 field goals this year, so he was thrilled. Like I said, I'm extremely grateful to the coaches who have worked with him, because when they tell him, to be resilient and be tough, he listens. When I tell him the exact same thing, he ignores me. On that note, that's why I got into football, and that's why I wrote the book. I am obligated by my employer, which is Hennepin County Medical Center, to make disclosures. I have intellectual property related to concussion diagnosis, brain injury assessment, assessment of atrophy or dementia after brain injury, and I also have, I'm an employee, a consultant, or an officer or a member of all of those organizations, none of whose opinion I am representing today. So anyway, I know brain injury is something that you guys really have to hear a lot about, unfortunately, and probably everybody's asking you about it. The Gophers coach who was up here just before me gave the first half of my talk when he said car accidents are, the biggest problem that people face, that causes brain injury. And that's absolutely and completely and entirely true. If you want to look at what kills kids, how do they get brain injury? Number one is texting and driving. 11 American children die every single day texting and driving. So if we were going to try and eliminate brain injury, taking out football would do absolutely nothing, but eliminating cell phones from cars would probably make a huge difference. So that's number one. In kids in particular, the causes of brain injury death are accidents, homicide, and suicide. And of those three, the one that is rising most rapidly is suicide. And I find that, that's something that's very complex and very compelling, and we'll talk a little bit more about it as we go along. And then half of all brain trauma occurs in people who are intoxicated. So if we really wanted to eliminate brain injury or reduce brain injury in this country, we could try and go back to prohibition, but we've all seen how that worked out. So really, brain injury is not something that, people talk about football and they think about brain injury, but really what they should be thinking about is, cell phones, beer, and cars. And those are your big things. So the issue that, you guys probably sort of get asked is, well, I read in the paper that, some football player died, playing football, and that's kind of a big deal. Whenever a football player dies, it's going to make the press. It's going to make the media. It's going to be all over the place. People count, they keep track of how many people died playing football. Well, the reality is that exactly like your Gophers coach said, riding in a car is 144 deaths per million participants in the United States. So that's, it's a certain very high rate. The highest rate for any sport is equestrian, and that's 20 deaths per million participants. Skiing, snowboarding, skateboarding, biking, all of the road sports and the speed sports, any sport that requires a helmet, basically, is going to be around 15 deaths per million. Football, this year I think there were about 10 deaths in football that were all reported, all of them at the high school level, none of them at the college or NFL level. Come back? Okay, good. So playground activities, that's less than 10 deaths per million. And then you've got other sports that are hard to quantify, things like swimming. So swimming actually causes far more deaths than football. It's 140 pediatric deaths per year. But the reality is that not all of those are participating in active sports. Some of them are drownings at home. And the funny thing is whenever I'm sitting around at dinner and people say to me, well, don't you see a lot of sports injuries? I do see a lot of sports injuries, but this particular season, you'll never guess which sport I had the most injuries from. It was swimming. We saw 2 kids who were in the pool on the swim team, and someone else dove in on top of them. And, in both circumstances, both kids were injured. One kid was injured with devastating injury, devastating spinal cord injury, devastating brain injury. You don't think about swimming as a cause of brain injury, but it really is. This stuff never makes the media. People will talk about football ad nauseum, but they won't even mention the other things. My research is all on brain injury, and that's really what I've been working on for the last 15 years. So I sort of have to talk about that. When you think about the long-term consequences of brain injury, really there are so many different things that can go wrong, and there's so many complex problems that can develop after a brain injury that you have to sort of consider all possibilities. So the first is, with every brain injury, you have to think about spinal cord injury because there's a 17% overlap. So there's obviously paralysis is something that can happen. With flexion extension of the neck. So classically in a car accident, someone's head jerks forward and backward, and they can shear the pituitary gland off their hypothalamus, and then they end up with hormone problems. And these are the kids who come in and they're depressed 3 months after they were in a car accident, and nobody knows why. And that has never been documented, by the way, from football. Then there's the inner ear, so that controls balance, and that's why you sometimes get people who have dizziness or balance problems after a brain injury. There's cortical spreading depression. So this is one of the causes, or thought to be one of the causes, of post-concussive headache. So when you have someone who has a brain injury, and maybe at first it doesn't seem that bad, but then over time they get worse, they may get headaches, they may have seizures, they can even have strokes. What that is due to is not damage to the neurons themselves. The neurons are still intact. It's the gradient of ions on the sides of the neurons that get messed up. And that can actually be fixed with medication if it's diagnosed. So these are problems that can happen down the road. And then there's what I think of as sort of the neurosurgery spectrum of problems. So when someone gets hit in the head, it can just be a soft tissue. It can just be the scalp. It can be the skull, that's damaged. You can have a fracture. You can break your bones in your skull. You can have bleeding on the surface of the brain. You can have bleeding within the brain. And then you've got sort of the elephant in the room, the diffuse axonal injury, or CTE. And this is really what everyone's freaking out about with football. They're worried that the subconcussive hits are causing CTE. And so we're going to talk about that in a lot more detail, because that seems to be like the biggest thing that people are really concerned about. And then anoxic brain injury, this is the type of brain injury that you get when you get someone, for example, who gets knocked out and they stop breathing, or their blood pressure drops. So like if usually it's car accidents, but it would have to be a pretty hard hit. But if someone drops their blood pressure or they stop breathing, the oxygen doesn't get to their brain. And so then they have permanent deficits. And these are the people that you classically think of when you think of people with really bad brain injury. So which of these, I just talked about 15 different problems that you can have after brain injury. So which of them has been shown to be more common in football players? And the reality is that there have not been controlled longitudinal studies that show any of these are more common in football players. And I mean, when you look at the media and what the media is doing right now, it's unbelievable to think that this is the case, but it is indeed the case. One of the things I talk about in my book is the quality of scientific evidence. In order to have good studies, you have to have controls. You have to have populations of people who are doing similar activities to what you're testing to see if the activity that you're testing is causing a problem. And so the only longitudinal studies that we have one good longitudinal study of NFL players, and we have one good longitudinal study of high school players, and then we have the NCAA studies, which are actually pretty good. We've got 3 good studies, and none of those studies show that, for example, seizures are more common in football players. They are not. So this is a study that was published. It was an NFL study. It's 3,439 NFL players. They were followed for 30 years after retirement from the NFL. They all played a minimum of 5 years in the NFL. Their mortality, so their death rates from cancer and heart disease, were lower than the general population, and they had half the suicide rate of the general population. They had musculoskeletal disorders, they had joint problems, and they had spine problems at 3 times the rate of the general public, which doesn't surprise me because football does take a toll. And these are people playing in the NFL, so it's the professional level. What about suicide? So the best data on suicide comes from the NCAA studies. So we just saw NFL data on suicide that shows that football players have half the rate. The NCAA just published this paper, October 2015, 9-year analysis of people who commit suicide in the NCAA. And among males in the general population, actually anesthesiologists are the highest. So people worry about their kids becoming football players. What they should really worry about is their kids becoming anesthesiologists. And some of that is an access to meds issue, obviously. So, and also they know how to kill themselves. So it's 19 per 100,000. In the general population, this thing is really annoying. In the general population, it's 12 per 100,000. Among college students, people who are in college enrolled at the time, it's 9 per 100,000, so it's lower. NCAA football players are 2.25 per 100,000, and NCAA athletes, so people who participate in sports at the NCAA level, it's a very low number. So suicide, the problem is that if someone commits suicide and they're a football player, it ends up in the media. If someone commits suicide and they weren't a football player, it doesn't end up in the media. So, when people have an N of 1, they can make a big deal out of it, and that's not good science. So maybe you're not worried about, death. Maybe you're worried about dementia, because obviously dementia is the big thing that people think about when they think about football. They think that all these players are ending up demented. So 1/3 of all Americans have had a concussion in their lifetime. 2/3 of all brain trauma happens in men, and that's probably because there's increased propensity for risk-taking behaviors in men. Dementia has an incidence of 63.5 per 1,000 persons in the United States. It's about 5 million people have dementia, have Alzheimer's. It's twice as common in women as in men. There's no reliable diagnostic. The causes are unknown. There's a lot of speculation. And we're going to talk about some of the risk factors. The other common types of dementia, vascular, frontotemporal, and normal pressure hydrocephalus, are less common. So what are the risk factors? Number 1 risk factor, high blood pressure, diabetes, sedentary lifestyle, people who sit around a lot, high-fat diet, frequent alcohol use, female gender, like I said, it's 2 to 1, more common in women, low socioeconomic status, and this is particularly true in women, smoking, atrial fibrillation, so any heart defect can cause it, genetics, so the ApoE4 allele has been associated with it, decreased level of education, particularly in women, and then there's been studies that have shown, and the most recent study was a California epidemiologic study that showed mild brain injury, if it occurs over the age of 65 years, particularly in men, increases risks for dementia. Moderate or severe brain injury, if over 55, increases risk for early onset Alzheimer's. So most children are actually thought to be resilient enough that a single concussion in childhood does not increase your risk for dementia. And I get asked that literally every single day. Every single time I have a young patient come in with a brain injury, the parent says to me, is my kid going to grow up to be demented? And I say to them, well, if your kid becomes a hypertensive, obese, diabetic smoker who doesn't finish school and doesn't engage in exercise, then maybe, Because the reality is that brain injury is a relatively lower risk for dementia. So now everyone's in the news talking about chronic traumatic encephalopathy. And this is probably, it used to be that nobody understood concussion, and that there are 43 different organizations that have posited a definition and diagnostics for concussion. Now the same things happen to CTE because it's become a complete mess. It was first discovered in 1928 by a pathologist in New Jersey who was studying boxers. And then it was it wasn't initially called dementia pugilistica, but that came along later. It was described in JAMA, which is a very reputable journal. And then it became more widely known. And in 1969, there was a very nice paper published based in England, in London, England, Queen Square Neurology, which for those of us who are in the field of neurology or neurosurgery, it's considered like the Mecca, where they did all the best work in neurology and neurosurgery in the early 1900s was in Queen Square. And what they did was they did a very nice study of several thousand boxers, and they found that 17% of living boxers had a disorder that was characterized by motor problems, which means trouble moving the muscles, and dementia. And that was called chronic traumatic encephalopathy. The term itself was coined in 1969. Bennett Omalu did not come up with it. He's a very compelling speaker, and he's obviously very good at selling his argument, but he did not name it. And it was described in England. Then what happened in the 2000s was there were several separate groups in America who wrote papers on finding CTE in football players. And the first paper was the one that they just made the movie about, the concussion movie, and that was Bennett Omalu's paper. And then the second group was the Boston group. And basically, the interesting thing about this was the pathology that they described was different from the pathology that had been originally described by the English group. So the uproar that happened, a lot of people, if you watch the movie, they make it sound like it was the NFL that was upset. It wasn't the NFL, it was the British neurologists. The British neuropathologists were very upset because they said, you're calling something else CTE. We've already got a disease called CTE, and it has different pathology than what you're describing. They were concerned that what Mike Webster had, he had dilated cardiomyopathy. He was, the first patient that they described, and he also had alcoholism. He had two siblings who had died of bipolar disease, He had, massive psychiatric disorders in his family. They were concerned that what they were seeing in this patient was actually something else. So the uproar and the call for retraction of Bennett O'Malley's paper was by the pathologist, and his paper was actually rejected by every single pathology journal and published in the Journal of Neurosurgery. So the British were upset about what the Americans called CTE, and they said, the CTE as defined in America is not a neurologic entity, but a cultural specific social phenomenon. And that was an editorial that was published in the British Medical Journal. And then the Canadians wrote back with another paper, and they said, well, you may see this in American football players, but we don't see it in Canadian ones with multiple concussions and neurologic symptomatology. And so there was actually enough controversy that there was a paper that was published in 2014 saying that CTE was not actually a real disease. What it was a collection of different problems that can happen in people from different causes. And the biggest cause that was purported was the use of opiates. So a lot of football players, especially in the NFL, have taken painkillers. They've taken morphine, they've become addicted to opiates. And it's well known that phosphorylation and mislocalization of tau, which is the protein that's been implicated in CTE, is also affected by opiate abuse. So there was actually enough concern that people wrote papers about it. Because there were now 3 different definitions of the CTE, and that was a problem. There were 2 American definitions and the British definition. The NIH said, okay, let's have a conference. Let's all get together and let's agree on a definition because we're not making sense, and people are thinking that CTE is an opiate disease and we think it's a brain injury disease. So they had the conference. It was in February 2015, and they got together and they came up with the definition of CTE, chronic traumatic encephalopathy, and they decided there were 4 kinds. And of those 4 kinds, 2 of them are thought to be clinically asymptomatic. So that's what they came up with this was published actually in December 2015, Acta Neuropathologica. So it was published really recently. And then they wrote a very nice paper. This was this Queen Square group, the people who came up with the original definition of CTE. And they said, okay, if we're going to use this American definition, then it's equally common in people who have dementia and people who don't have dementia. So, CTE has now become a completely different disease than what was originally described by the Queen Square group in 1969. But if you're going to call it that, and you're going to say there are 4 types, then we're going to say that it's exactly as common. It's 11.8% in people with neurodegenerative diseases, and it's 12% in normal healthy controls, people who died at a mean age of 81. And this is what they did when they looked at their brain bank. So in other words, you can say that you find CTE in everybody, but it may or may not be associated with any symptoms. And then a lot of people probably heard about this paper because this was in the news, I think about a month and a half ago, and then it was on ESPN last month, and it was kind of a big deal. This was the paper that got published by the Mayo Clinic group in Florida saying that 1/3 of all people who played contact sports were going to have CTE, right? And that was a big deal because they said in 21 out of 66 former athletes, of whom only 3 had prior concussions, they had CTE. And it was not seen in 198 non-athletes. But if you read the fine print on the paper, what it tells you is that there is no association between clinical symptoms and CTE. So it's really sort of an interesting conundrum because whenever the media decides, like Frank Gifford had CTE, the guy lived to be 84 or 81, I can't remember exactly, and he was on TV, he was talking, he didn't appear to be all that demented. So, maybe he had the CTE that's clinically asymptomatic, I'm not sure. But, it's created this hysteria where everyone's terrified their kid's going to end up with CTE or some form of dementia, and the reality is that the way we've defined it now, it's not always clear that it's a real disease. And then this paper just got published 2 days ago in Journal of Neurotrauma, and this is from the Boston group again. And what they've done is they've looked at 93 former football players, and they've said that these former football players are at risk for these problems, and the number of impacts that they had in their lifetime is proportionate to the number of problems that they have. And the problem with these types of papers is there's what's called a selection bias. If you are in Boston and you're Ann McKee's group and you've written all these papers about CTE and you open up a clinic and you say, come to us if you have neurodegenerative symptoms, and then you get a whole bunch of people who come to you and you study them and you have no controls, then of course those people are going to have problems. They came to you because they had problems, right? And you're not necessarily going to get a cross-section of people who weren't exposed to football because that's what you're advertising. So then when you publish a paper saying that, former football players have a problem, it's because you've advertised that you're selecting for that group. So it's a longitudinal analysis without controls. That's what we call selection bias. So to ask your question, does football increase your risk of dementia? You've got a couple of different studies. You've got NCAA studies, you've got NFL studies, and you've got a high school football player study. This was a paper that was published, I think in 2012. Mayo Clinic group, 438 football players, Rochester, Minnesota, played in high school. They were followed for 50 years, and they had the same risk for dementia as members of the chorus, glee club, or band. So the reality is that, if playing the clarinet is the same as playing linebacker, then you really got to worry about what we're telling kids when they can't play football. So in our book, Football Decision, one of the things that we did was we did a survey, because, anecdotally, every time I sit around with a bunch of people at lunch and they all happen to be surgeons, every single one of them tells me they played football. And I always find that interesting because, they all seem really cognitively well. And it turns out that we did a survey of all the neurosurgical department chairs, and when we did the survey, we got 155 department chairs in the country. 65 of them responded to our survey. So you got to figure that only the ones who either like me and know me or like football responded. So we probably have a selection bias. But of the ones who responded, 1/3 played football in college, or other contact sports in college. So in blue is the number that played football in high school, and in green is the number that played football in college. And you can see that the numbers are disproportionately much, much higher than the general population. In the general population, only 8% of high school students and 0.7% of college students played football, whereas among neurosurgeons, it's a substantively higher percentage. Neurosurgery chairs were therefore 16 to 40 times more likely than the general population to have played football in college. And it's funny because I talked to some of my colleagues about this, and I was like, well, what do you think is going on here? Why are neurosurgeons so likely to have played football? Number one, risk-taking behaviors. Number two, toughness. These are people who get up in the middle of the night and go operate on people and cut people open. And it's a very similar mentality to what you guys teach. There's no question that you have to be really, really resilient and tough to be a neurosurgeon. And so, I talk about this in my book. I talk about risk-taking behaviors. And one of the things, I don't know if anyone was here at the Bennett Omalu talk. Bennett Omalu is sort of the big person, he's a neuropathologist, and he's the one sort of saying that any sport that requires a helmet should be banned for children. So he's saying biking, snowboarding, skiing, football, hockey, all should be banned because you're not meant to use your head. He thinks that that's just not how it should be. And then he went on to say that his 6-year-old son wants to be a neurosurgeon. And I'm sitting here thinking, well, if your son doesn't engage in risk-taking behaviors as a child, how's he going to do them as an adult? That it's an interesting problem. So among neurosurgeons, when we did our survey, 30% of children of neurosurgeons have played contact sports. 83% engage in other risky sports. So if you look at your number one risks for brain injury, biking, skiing, snowboarding, skateboarding, they're all represented among the children of neurosurgeons. And then the neurosurgeon opinion on banning sports. And there's a lot of press right now. There've been a couple of people at the University of Minnesota who are, interestingly enough, people who they don't study brain injury. They study ethics. So there are a couple of ethicists at the University of Minnesota who've written editorials saying that football should be banned, hockey should be banned. These kinds of people, they don't understand brain injury, first of all, but then they don't understand statistics either, and they don't understand scientific evidence and how to read papers. So that's really a problem. But the neurosurgeon opinion, so when we did our survey of neurosurgery department chairs, the vast majority did not favor banning football. They did not favor banning even checking in hockey, which I found interesting because you could probably preserve much of the nature of hockey even if you banned checking, but they didn't favor that. Nor off-piste skiing or some of these other dangerous activities, which are substantively more dangerous than football. So really, the take-home message here is brain injury is the problem. It's not sports that's the problem. if you look at statistically where kids are getting brain injury, it's not from sports. And it doesn't matter if it's football or hockey or soccer or something else. In my kid's high school, he's in the IMAC league. The #1 sport for concussion this year was boys hockey. And then I think #2 was girls soccer. And football actually was, I think, really far down on the list this particular year. Football is a very, very popular sport. I don't have to tell that to you guys. It's the #1 sport for high school children, or at least it was up until, recently. It's more popular than track, which is #2, and basketball, which is #3. And really, my perspective on this is if even half of those kids who are playing football right now are told, okay, we're not going to have football at your school because, we can't afford the insurance, and we're worried about brain injury, and we're worried about, all the different things that can go wrong. If half of those kids don't go out for another sport, the resultant increase in, societal problems, hypertension, obesity, diabetes, sedentary lifestyle, video games someone mentioned, it would just be enormous. The psychosocial impact of banning football would be absolutely terrible. And there have been papers that show that even the obese child sees a cardiovascular risk reduction from playing sports. So, like my kid, for example, he's already told me, he says if he can't play football, he's not doing cross country and he's not doing soccer. So, there's nothing else in the fall. What do you tell these kids? It's not fair. It's really not fair to the kids to take away the sports that keep them active and keep them, socially involved with other children and their teammates and their coaches. When we don't know that there are real risks from brain injury for the sport. And then finally, I just end with the American Academy of Pediatrics recommendations. All of us, none of us in this room ever want to see a kid get hurt. We want our kids to be tough, we want them to be resilient, but we don't want them to get hurt. So, that's important, is that we make sure that we're avoiding the types of contact that can result in injuries. The American Academy of Pediatrics also recommends reducing contact drills and practices because, unnecessary blows to the head are probably not in the child's interest. Neck strengthening has not been clinically shown in any trial to reduce brain injury, but it's thought to be the mechanism by which more women have concussions than men, because it is known that if you look at frequency, concussion is more common in women, and it's thought because they have less strong necks. The mechanism of concussion is classically thought to be a flexion extension, and if the neck is strong, then that may prevent that. And then the tackle technique improvement. So people have talked about using rugby-style tackling, and that's really what probably needs to happen. Is there need to be some changes so that we can make the sport as safe as possible so that people don't freak out. And then finally, the last sort of thing that I would say is when an injury occurs, a kid needs to get treated. Because, one of the big myths of brain injury is that it's not like any other disease, that there's no diagnostic and there's no treatment. And that is changing. We just started at Hennepin County Medical Center the largest clinical trial in the country, single center clinical trial in the country, looking at classification of brain injury. So what we're doing is we're doing serum blood tests, we're doing eye tracking, we're doing radiographic measures, including MRI. We're classifying brain injury so that we can figure out exactly what's wrong, and then we can develop targeted treatments so that, for example, we know that, some kids need to rest, some kids don't. Some kids need ocular motor testing and rehab, some kids don't. Some kids need balance, rehabilitation, other kids don't. Every single brain injury is different, and every single kid needs to be figured out and treated differently. And that's really the important thing, is that if we recognize that this is, something that we have to take care of, then that's what we should do. And that's really it. Thank you.